In this 7-part lecture series, I'm going to explain the most important aspects of documentation and reimbursement. If you haven't watched my first video in the series, please watch that video first before you proceed, since it's an introduction to the more complex documentation topics. And I'm going to frame these lectures for the busy emergency medicine doctor. I don't want to discuss the minutiae of the guidelines, rather I want to discuss the major concepts of appropriate documentation and reimbursement for the services that you already provide. These lectures are heavily influenced by this website, the ACEP Reimbursement FAQ, which will be linked in the comments, as well as from my experience serving on the ACEP Reimbursement Committee and the ACEP Coding and Nomenclature Advisory Committee. And although we'll be discussing the billing and reimbursement side of documentation, please remember that your documentation is also very important for medical transitions and care, as well as medical legal purposes. First, we need to understand CPT codes. CPT codes are the standardized set of 5 numbers to describe and bill for medical procedures and services. There are thousands of CPT codes in use, but in emergency medicine, there are just 5 CPT codes that make up about 85% of all CPT codes submitted for reimbursement. These are the 5 Evaluation and Management CPT codes, often referred to as E&M codes. These 5 CPT codes are super important, so let me explain. The CPT codes range from 99281 here, aka a level 1 chart indicating the lowest acuity and complexity, to a 99285 chart down here, or a level 5 chart, indicating the highest acuity and complexity without accounting for critical care CPT codes. If you're curious, the other 15% of CPT codes are from critical care and procedures. Now let's look at the RVUs associated with each code. If you assume each RVU is worth about $32 in 2025, then you can get an idea for how changing an E&M CPT code will change your emergency department's overall billing and reimbursement. So moving from a 99283 or a level 3 chart to a 99284 or a level 4 chart, you gain about $50 extra per chart. The same is true from going from a 99284 chart or a level 4 chart to a 99285 chart or a level 5 chart. Again, you get about $50 extra. Therefore, documenting more accurately will lead to more appropriate billing for the work you are already performing. As you can see, there are 3 factors that lead to different E&M codes. The number and complexity of problems addressed, which we'll refer to as COPA, the amount and/or complexity of data to be reviewed and analyzed, which we'll refer to as data, and the risk of complications, morbidity, mortality of patient management, which we'll refer to as risk. This information is mostly extracted from the MDM section of your note. Thus, the MDM portion is where the physician's cognitive efforts are displayed and billing is determined, so it is of critical importance. Let's first focus on COPA, or number and complexity of problems addressed. Now, technically, it's more accurately referred to as NCOPA, but since most people still use COPA, that's what I'm going to use in this video. It's not important to memorize the definitions of all these terms, such as severe or progression, systemic symptoms, injury, etc., because most emergency medicine doctors won't be doing the coding. Instead, let's talk about the big picture here. As you may expect, COPA is measured by 2 factors, the number of problems addressed and the complexity of those problems. So, starting with the number, you should discuss any medical condition that you treated or any comorbidity that influenced your treatment. You will get more points for COPA for an increase in the number of problems addressed. Here are some examples of often forgot about medical conditions addressed. Treatment for hypokalemia. If you gave the patient oral or IV potassium, you should document it. Treatment for dehydration or acute kidney injury if you gave the patient IV fluids. Treatment for hyperglycemia if you gave the patient IV fluids or insulin. Treatment for nausea if you give them antiemetics, or treatment for tachycardia if you gave them IV fluids. Another important point, simply listing that a patient has a comorbidity such as cancer does not increase the complexity of the visit. You must document how the cancer influenced your workup. For example, you may document that additional labs or imaging were needed due to the cancer. My last point on number of problems addressed is that multiple problems of a lower severity may, in aggregate, create higher complexity, so document all the problems addressed. Moving on to complexity of problem addressed, the main point here is that you must discuss your differential diagnosis. Just listing chest pain in the MDM is not very good. It's much better to document, due to the patient's chest pain, I evaluated for cardiac ischemia. This will likely increase the COPA from moderate to high. And cardiac ischemia doesn't even have to be the final diagnosis. Evaluating and ruling out life-threatening diagnoses produces a high COPA. Here are some more examples of common chief complaints where doctors often don't adequately explain their level of concern for a potentially life-threatening diagnosis. Abdominal pain. If your workup included an evaluation for ectopic pregnancy, acute intra-abdominal infection, or ovarian or testicular torsion, you should document it. Dizziness, if you're concerned for stroke or arrhythmia, document it. Headache, if you were concerned for intracranial hemorrhage. Dyspnea, if you're concerned for cardiac ischemia, heart failure, or pulmonary embolus. And finally, syncope, if you're concerned for arrhythmia or seizure. Those are all life-threatening diagnoses. But please do not use an expanded differential diagnoses for situations where you're not actually concerned for the pathology listed. For the last part of the video, I wanted to mention the final diagnosis. It's very clear that ACEP states that the final diagnosis does not determine the complexity of the problem addressed, or COPA. An extensive evaluation may have been required to conclude that the patient's signs and symptoms did not actually represent a life-threatening condition. However, many insurers are now using computer algorithms to review the patient's ED chart to determine the final E&M CPT code. One example is UnitedHealthcare's Emergency Department Claim Analyzer, which uses, quote, deep clinical expertise and, quote, industry-leading technology to determine their opinion about the correct E&M CPT code. And yes, it used the final diagnosis via the ICD-10 codes on the patient's chart. This often leads to downcoding or denials. This should not happen, but it does. You can read more about UnitedHealthcare's Emergency Department Claim Analyzer from the link in the show notes. The discussion about ICD-10 codes will be further expanded upon in Part 6 of the series, but my main point is that you should list all ICD-10 codes for all diagnoses found and treated during an emergency department visit. In summary, mention all problems addressed during the ED visit, such as abdominal pain and dehydration, vomiting and hypokalemia, cellulitis and hyperglycemia. In addition, you should discuss your differential diagnosis. The MDM portion of your chart is the main determination of the final E&M CPT code, and therefore it is responsible for most of your department's billing. In the next video, we'll discuss the data portion of the MDM. Feel free to post any questions in the comments, and I'll try my best to answer them.